Hello, everyone, and welcome to another episode of Scoliosis Dialogues. I'm one of your hosts, John Vorhies from Stanford, and I'm joined by
Masood Shafafy from Nottingham University Hospital in UK. It is my pleasure and privilege to be part of this podcast.
Today's episode is all about research grants. As you may know, earlier this month, we had our first SRS Research Grant Outcome Symposium, which was moderated by Dr. Douglas Burton and Rene Castelein. In that symposium, some excellent work was highlighted by a number of recent recipients of SRS grants. Today in the podcast, we'll interview Dr. Castelein, who, in addition to hosting the recent Outcome Symposium with Dr. Burton, is also the Research Promotion Oversight Committee Chair. We'll also talk with Marinus Kleuver, who is the Research Council Chair. And additionally, we'll chat with Dominique Rothenfluh, who is one of the presenters during the Research Grant Outcome Symposium and is doing some important work developing a disease-specific patient-reported outcome measure for adult spinal deformity. So to start things off, I'd like to just mention a few of the statistics about the grant program, which were presented by Dr. Virginie Lafage during the Outcome Symposium. Since 2012, the program has awarded over $2.1 million through 75 individual grants. These were awarded to investigators in 9 different countries across 3 different continents. The work funded has resulted in a number of great presentations, abstracts, publications, and many of which are award-winning and practice-changing. The program has changed a bit over the past few years, and now applications are accepted over a single cycle, usually open for submission during February and March. There are large grants designed to be awarded to experienced research teams, but there's also a number of micro grants for exploratory projects, new investigator grants, and also grants designed specifically for residents and fellows that have a more streamlined application process. For more information, I'd encourage anyone who's interested to go to the SRS website and see what's available. I would also encourage our SRS members to talk to residents and fellows about potential projects and to support them as they apply for a trainee grant. We'll start things off by talking with Marinus de Kleuver. He's a spine surgeon and a chair of the Department of Orthopedics at Radboud University in the Netherlands. And aside from that, he's also chair of the Research Council. Thanks for joining us today.
Good morning or good afternoon, John.
I was just wondering if you could review a little bit the structure of SRS governance for those of us who aren't familiar with it, and tell me, so what is it that the Research Council Chair is responsible for?
Yeah, so John, interestingly, we've remodeled this recently over the last couple of years. The Research Council represents several committees. Obviously, the one we just talked about is research grants. So people can apply for a grant, and the Research Council independently reviews those grant applications. And since last year, we separated grant oversight from grant application. So we now also have an oversight committee that looks at whether these grants actually complete their work, how the funding was, what the results were. And we've called this committee the Research Promotion and Oversight Committee. And this committee also hosted this recent symposium, because I think we have underperformed in the past years is actually how well we've worked. You know, if you're good, you should spread the word. And over the last years, as you mentioned, we spent millions of dollars in grants, but we never really promoted the SRS in this. And so the idea is that we should be more proud of what we do. And so we initiated this new committee, Research Promotion and Outcome Committee, or Oversight Committee. Then we have always had, since the initiation of the SRS, the M&M Committee, Mortality and Morbidity Committee. That committee is somewhat in transition at the moment because we realize that the M&M Committee, which all of us as members have provided data for, is becoming somewhat outdated. The data that we are collecting is probably not granular enough. It's also, there's some discussions about how compliant we are. And so we are looking at transitioning this committee into a benchmarking committee. And that is ongoing work. But for at least this year and next year, it's still called the M&M Committee. And all of you are contributing to it. And if you're not contributing, you're paying the $300.
I think that deadline is coming up, too.
And the deadline is coming up because I'm very aware of this because I actually completed my submission yesterday. And we all know it's a lot of work. And the deadline is indeed April 1st. So April 1st for everybody to be aware. Then the fourth committee is Safety and Value. Also, a traditional SRS committee, which is very important. The Safety and Value Committee, for example, last year published the new neuromonitoring statement. They're developing a repository where members can have data and checklists, for example. So the Safety and Value Committee is also a traditional SRS committee, which we will maintain. And finally, under the Research Council, there is still the Pediatric Device Task Force, which is run by the SRS together with POSNA. That's the Pediatric Orthopedic Society of North America. Probably this task force will be positioned in a different area within the society. So for now, it looks like these are the 4 main committees of this Research Council. And we intend to install a fifth committee, which will be a compliance committee. And then we're looking at research compliance and data compliance, because we realize more and more that as people are providing data to our society, we need to make sure that we're compliant with privacy rules. And those are very different all over the world. So for procedures such as M&M submissions, grant submissions, we will start to facilitate our members a bit more by having a compliance committee, but that is still work in progress. So currently we've got M&M, safety and value, research promotion and oversight committee, and the traditional grants committee.
Great. Thanks for that. I wanted to ask you a little bit about your career development. Obviously, you've been involved in SRS governance for a number of years, but for our younger surgeons and listeners, can you tell us a little bit about how you became involved in the SRS?
That's a wonderful question. And it's people can't see it, but I've got a smile on my face now. My mentor was a senior spine surgeon called Gerard Slot, and most people won't know him, but he was a close colleague and almost soulmate of Zielke, who developed the anterior spinal surgery implants. And Gerard Slot was one of the early international members or fellows of the society, and he used to go to the SRS annual meetings. And I remember in 1997, he wasn't going, and I went to my first meeting in Cairns. And I had no idea where I was going. I'd submitted a poster, it had been accepted. And I thought, well, I'm just going to a spine meeting somewhere on the other end of the world. What am I doing here? And it was a wonderful meeting. And what really inspired me was how senior members took young people like myself at the time under their wings. And since then, multiple times, especially in my early years, I can remember multiple senior members meeting them on a bicycle trip. I remember I was on a bicycle trip on a Thursday afternoon when the meeting was in Salt Lake City, and you're suddenly talking to a board member, and you suddenly, the names you've always read about in the literature, and you're suddenly sitting next to them. And I think that's one of the wonderful aspects of our society, is that there is a very strong community aspect, which most people don't verbalize and make so explicit. But for me, that is hugely important for our society. So if you can stand up and feel comfortable talking to people and approach people, despite the fact that the SRS has a certain reputation as being exclusive, we are to some degree exclusive because we want to make sure that our members are spine deformity surgeons who are committed to our society. But once you are willing to contribute, I find it an extremely inclusive group.
Yeah, I found it to be that as well. And, it's a great thing to be involved in, especially coming from the U.S., because many of our societies and groups are so insular within the U.S. I think that the international nature of the SRS is a wonderful thing. It helps get people exposed to ideas that come from different healthcare environments.
Absolutely. And again, another example is that before I knew it, Larry Lenke invited me to a meeting in San Diego to talk about internationalization of the society. And that for me was a landmark. Suddenly I'm sitting in a hotel, one of those large hotel meeting rooms, which is somewhat anonymous. But suddenly you're sitting in the room with people who in your eyes are the giants of the world. And so suddenly you realize that how international our world is, how international this society is, and how we're all grappling with the same type of issues in the context of our own healthcare systems. And I really, really cherish this international aspect and meeting people and discussing cases. There's something very special about the society in that aspect. And that really jumpstarts research as well, because often it's at the coffee machine or in those meetings that you can talk to people. You suddenly feel that or identify areas where you're looking at the same problems. And research tends to develop, especially at these type of meetings. The ideas are incubated there, as it were.
So I'd like to shift gears a little bit back to the research grants program. One of the cool things about being a candidate member is that we're all expected to serve on a committee. So I got to serve on the research committee and learn a little bit about how research grants are selected and the process. Also had the pleasure of being rejected for an SRS grant.
Haven't we all?
Yeah. So I wanted to ask you about your experience with applying for grants, what has failed for you, what has worked for you, and what advice you might have to people who are starting up projects.
So my first advice would be don't give up. And the second one would be do some homework beforehand. In other words, it's not a political game. I don't mean by doing some homework that it's politics, because it's an independent review process, which is very closely guarded. And, for example, the council or the presidential line or the board has no influence, and it's all very much a separate, clean process. But what does help is guidance in how you write your papers, how you write your applications. And one of the things that we struggled with within the SRS originally is that the classic research grant application process is investigator initiated. So whichever idea bubbles up in someone's mind, they can submit. The grant committee looks at whether it's a good project, and then they will or will not grant the monies. The SRS has struggled a bit with giving some more direction to research, because if we as a society say some area is extremely important, but no one submits a grant in that area, then we are not in any way setting the direction of research. So one of the things that I think is important is that society has provide extra funding for directed research. But if you want to submit an investigator-initiated research grant, it requires a little bit of groundwork, talking to people, what's hot in spine research, where are those little pearls that where you think that you can bring people together. So I think submitting a grant requires actually a lead time of probably more than 6 months. And not, you get the newsletter saying, oh, the deadline is in 3 weeks, then you're too late. Because grants like this, they work through well-written proposals. They need to be very well-written and relevant, and often talking to people, batting it back and forth. I think the expression in Dutch would be ping-ponging the grant proposal back and forth, helps make it better. So lead time, involving some senior members. And there are lots of senior members who would be prepared to just mentor you without being grant application themselves. So I think talk to people. There's not such a big concern here for proprietary interests. To talk to people, do the homework, and if you're not in time, just apply again next year.
Great. Yeah, I think the directed research grant idea is very interesting because there's so much money involved in it. It has the potential to change the direction of the field.
Yep.
But also, I wonder if the directed research grant might target a certain type of applicant, because an early applicant, I might choose a research study based on what I think I can do best and what I see
Absolutely.
best, not necessarily what the field needs, because I want to make the highest quality research I can.
I think, but both are very relevant. So if you look at the aspect that the investigator-initiated grants are also developing our spinal community and developing our members' potential and allowing members to grow. So the fact that we are providing about $300,000 a year in monies available for investigator-initiated research is also a very clear member benefit. So we're not giving the money away, but it's not just that you're improving the care for patients with a spinal deformity, but you're also improving and building our community. And I think the directed research grants are larger budgets. They are usually multi-year projects, and they require often a consortium type of approach. And those are a little bit more like the professional. It's not the same as an NIH grant in the US, but they are certainly more serious applications. Whereas the nice thing about the traditional grants, they're usually about $50,000, $25,000 for 2 years. We have a strong vetting process, but it does allow you to explore and build your own research experience. So it's also aimed at developing members.
Great. So along the lines of discussing bigger collaborative projects, I wanted to ask you a little bit about your work with the Costco project. So later we're going to talk with Dominique Rothenfluh about his work developing patient-reported outcome measures. And so he mentioned you in his talk and how you might have contributed to the development of this. So I wanted to ask you about your work in that project.
Now that's a great example, John, because we applied for a grant separately from Rothenfluh, and it turns out we were exploring the same area, but the two sides of the same coin. So we were looking at how can you measure patient outcomes from a somewhat provider-oriented view. So looking at the doctors, researchers, how we think that you should capture outcomes. And that's using, for example, PROMs, but it could also be looking at X-rays, or you could use criteria like return to OR, somewhat traditional things. And we tried to bring that together to at least to speak a common language. And that was the aim of the Costco project, that we could identify a set of standard metrics that everybody could use for adult spine deformity. And that's, for example, take an SRS 22 or EQ5D or return to OR or infection rate. At least everyone should use the same metrics. Very interestingly, that's not very patient-centric. Even if you take PROMs or promise in the future, is it really what matters to patients? And what Dominique is doing, he's turned it around. He's actually asked patients, what matters to you? What do you think is a successful outcome? And whereas we as doctors may say, well, it needs to be a perfect X-ray, the patient doesn't care about the X-ray. They've got completely other concerns. And it turns out that quite a lot of the items that Dominique has identified are very similar to those that we as professionals have identified, which is not surprising because we tend to know relatively well what we're doing. But he's clearly also identified areas which we're not capturing so well. And interestingly, we from our provider side, researchers and surgeons, identified areas which we think are important, for which there are no metrics. For example, everybody realizes that in adult deformity, leg pain is important. Nobody knows how to measure leg pain. Even in the degenerative spine world, if you look at spinal stenosis, yes, we know leg pain is a driver of decision-making. There is no instrument to measure leg pain. And similarly, we know that a lot of patients develop shortness of breath, but there's no instrument to measure shortness of breath. So we're using the SRS 22, which was developed for children. We're using it in adults. We're using an EQ5D. We're using an NRS leg pain score. Yes, but we're missing areas. We really are missing areas. And Dominique is showing that we're actually missing areas that really matter to patients. And so we both have received an SRS grant, and we paired up. And I think that ultimately with Dominique's work and our work, we should actually really be able to make an impact on how we measure outcome for our patients and make it more standardized so that once you have an outcome measure in North America, you can compare it to my measurements here in Europe, and we can compare it to measurements in Asia. And that would really, really empower our field to show the benefit of our treatments, because then suddenly you've got large numbers, and ultimately with machine learning and large numbers, we should be able to show much more clearly what the benefit is of our surgeries.
I congratulate you for doing that work. It's certainly very important and very challenging.
It's challenging, yes.
Yeah. I have so many mixed feelings about it too, because we just finished our round of residency interviews at Stanford, and there's such a huge influence now in selecting trainees in avoiding standardized tests because of inherent biases in those. But then in some senses with patient assessment, we're running towards standardized tests as quickly as we're running away from them in education.
I think standardized depends a bit on what you mean in the sense of what's standardized, because hugely importantly, this is complexity science, and these are non-linear processes, and they influence each other. So just like you're trying to identify a resident who's good, he may be very good in language skills and very poor in mathematical skills. And those are very often interconnected, or they're good in their eye-hand coordination, or they're bad in something else, or they're really driven, but they're bad in patient contact. These different aspects need to be weighed in different ways. And I think that standardization doesn't mean linear metrics and having a simple thermometer that tells, this is where we stand. Probably with machine learning, as some others in our society, and Chris Ames, for example, have shown, is that you'll probably identify certain profiles of patients. And I think patient profiling is a better word than standard measurements. But at least once you want to develop profiles, you need to at least identify how are you going to measure leg pain without putting a value to it or saying this is good or bad. But at least we need to know how to measure leg pain. And we don't even know how to measure leg pain. So standardized measuring instruments doesn't mean standardized outcomes.
Yeah, well, it's certainly critically important if we're going to evaluate how effective our interventions are.
Absolutely. Completely agree with you.
All right. Well, I think that's kind of wrapping up the time that we have available. Is there anything else that you wanted to cover?
Yes, there is. I really want to compliment our society, because over the last 2-3 years, I've been very honored and happy to contribute to developing some of the ideas about where we need to go with our research. But it's just so inspiring to see how many of our members then actually step up to the plate and contribute. Just like you're organizing this, John. Rene organized the Symposium. The members in our society are so valuable. And I just talked earlier on about the community, but in the same way, looking at developing our society and taking the next step forward, all for the benefit of our patients. The membership here, as you progress through life in our society, as it were, I'm becoming to value that more and more. And I think it's a big thank you to everybody and also the team at the office to make all this possible.
I certainly second that. All right. Well, thank you very much for joining us today.
Okay. Thank you too.
And I would like to start by introducing my dear friend and professional colleague, Dominique Rothenfluh from Oxford University, a consultant spinal surgeon. I would like to start by asking Dominique, first of all, what motivation did you have and what was the reasoning for choosing this particular topic that has been covered so extensively in the past few years, i.e. creating a novel adult deformity scoring system?
Yeah, thank you very much. Thank you, Masood and John, for having me in this podcast. That's of course a great honor. Yeah, well, that's a very well taken question, because outcome measurement for most surgeons is kind of a daunting task, right? And especially then creating a novel outcome score. The reason why I came up with this topic essentially was because at some point I was interested in designing a randomized trial for adult spinal deformity, and in all the initial meetings that we had in order to come up with a protocol, very rapidly the question came up, what primary outcome measure would we choose? And when you then look at the landscape of outcome measurement in adult spinal deformity, we find that mostly the Oswestry Disability Index, which of course is very well known to us in Oxford, and the SRS 22 have been most widely used. The problem with these scores, however, is that they're not disease specific. So they've never really been formally validated for adult spinal deformity. And then the second problem is that they don't necessarily meet more modern psychometric properties. And with that, I mean properties such as linearity and unidimensionality. Linearity essentially means that's a very basic requirement in measurement. If we measure length, we have a meter, and we know that 3 meters is or yards or miles, whatever you want to take it, is just 3 times as much. However, if we measure disability or have some aggregate score, then double that score does not necessarily mean double the disability. And that's the main problem with all the ordinal outcome scores, such as the Likert scales and even the visual analog scales that are very commonly used. So these days, it's actually quite old already, but we can use a methodology which is called rash analysis, to some degree also latent trait analysis, which then allows us to ensure that the final outcome score actually has a linear scale, which then means that we can do inferential statistics with it. The other requirement that we look for is unidimensionality. So we would really like to make sure that the score really just measures one common underlying concept of the disease. That in our case with adult spinal deformity, where we have sagittal balance, but we also have more prominent coronal curves, we would really like to make sure that those two conditions, which we really summarize as one, are really on the same scale. And the reason why this is important is just go imagine going to a market and trying to buy a pound or a kilo of apples, and every day you come back, another day you come back, the scale actually shows something different, because depending on the time of the day or maybe the weather, the scale is calibrated differently. So that wouldn't make anybody very happy, but that's the difficulty that we're facing when we measure outcome in patients.
We know that there is a discrepancy between perceived outcome from the surgeon side and from the patient side. In your outcome score, how are you going to bridge that gap between perceived outcome by the patient and by the surgeon?
That's a very good point, because most of the scores that are most widely used really are surgeon derived. So they came, like the Oswestry Disability Index, very famously, Jeremy Fairbank, the first version of it was almost created on the back of a beer mat, right? So these days we can't do this anymore. And there's also there's actually very clear guidelines, for example, by the FDA, with an outcome score that then is supposed to be used in also commercial studies has to fulfill. And to us, that was actually clear in the very beginning, that we first had to ask patients what really matters to them. What do we have to measure? And we interviewed, for this reason, 100 patients. So 50 were interviewed in Oxford, 50 in New York, because there's a collaborative project with Virginie Lafage at HSS. And what we found was really that patients, what actually matters to patients, what their presenting symptoms are, what their limitations in everyday life are are not necessarily what is represented in the Oswestry Disability Index and the Scoliosis Research Society in the SRS 22 questionnaire. Actually, only a few items overlap with what we found in our open question interviews. And those items, those questions, we have to use those now to phrase the questions. And that's something we discovered only a bit further down the line, and that's why we have to kind of go back again and interview some more patients, because the FDA requires us to have written recorded transcripts of the interviews, and that exact phrasing that we find in there then has to form part of the preliminary questionnaire that we then start distributing to patients in order to do further work on it.
I wonder if I might jump in with a question. Yeah. So I think it's very interesting how you began this work by a series of open-ended questions to a population of patients. And I think that's critical because this is a patient-reported outcome measure. So you really need to start with what's important to the patient. But I wonder if you might tell me how you went about selecting that population of patients and how that might ultimately reflect what is best measured by your outcome score. I'm thinking about this in the context of a strive for diversity in our field. And if you select a certain number of patients with a certain type of deformity or a certain cultural background or socioeconomic status, how that might ultimately be borne out and who is best served by your survey.
Yeah, that's of course that's a key point really in how you create the outcome score. At this stage, we have to be extremely broad. So we use the inclusion criteria for adult spinal deformity that are being used by the ISSG and the ESSG, so they're quite widely accepted. So that guarantees that we have a very broad inclusion criteria. And then with regard to, cultural background, obviously they're limited now to, at the moment, they're limited to the population that we have in Oxford and New York that may not necessarily be representative. That's why we then need to do further validation. And the rash analysis gives us a few tools to do this. So first of all, we need to ensure that we then capture a very broad and representative set of the population. That means we need to widely distribute then the preliminary questionnaire, not just, in Oxford and New York, but we plan to do this across initially more centers in the UK and more centers in the US to at least have an English version. And then we can analyze the score for specific patient factors, such as, for example, whether they have a coronal or sagittal deformity, whether they're male or female, whether they have a idiopathic or a degenerative deformity, but also for any other person factor that could be cultural, that could be ethnic, that could be anything, and then see whether any of the items that may end up in the score behave differently. So is a certain set of patients, are they more likely to respond higher to a specific item or lower to a specific item than another group of patients? If that's the case, then we have what we call differential item functioning. And if we want to be able to compare those two populations, which means if we want them to be on the same ruler, on the same scale, then we technically have to eliminate that item. If we do not eliminate that item, then we may have to acknowledge that the score behaves differently, and their outcome scores then cannot necessarily be directly compared. And that's crucial. We saw this, for example, about 13, 14 years ago when I got into this methodology. I analyzed at the time I was still in orthopedic training. I analyzed the WOMAC for a condition called, which most of us are very familiar with, femoroacetabular impingement, particularly in the younger patient, but also to see, how they compare then to patient with osteoarthritis, so the older patient. We found, for example, with differential item functioning, that the younger patients with femoroacetabular impingement would rate pain while sitting much, much higher than the patient with osteoarthritis, the older patient with osteoarthritis. That's because that was their predominant symptom, and it was specific to that pathology. So if we keep that symptom in there, then we would have had to acknowledge that the patients with femoroacetabular impingement and osteoarthritis cannot be directly compared because they're overrating that item. And that's exactly what we want to exclude in this score.
I have a similar question along the same line, but Can you actually predict that in the future we could have a scoring system so granular that not only we can differentiate social classes and different ethnic backgrounds, also gender and also stratified age in adult deformity? Because what a 50-year-old perceives is not the same as an 80-year-old perception.
Well, the short answer is no. All that we can do is make sure that we're applying the same scale to these patients. And that scale will always just measure one underlying concept if it is a unidimensional score. But that's probably maybe a limitation of some of the randomized trials, because we have to choose a primary outcome measure. And we know very well from the value-based healthcare framework that outcome measurement should not be limited to just one outcome score. That's what we like to see and report in some of our studies, but it does provide a very incomplete picture, and it should include more dimensions. And the Porter defined a 3-tier system and how to measure outcomes. So it will always a single score, if it is done right, will always be just a measure of one concept of the disease. And it should ideally be consistent amongst all those groups and all those factors that you just mentioned.
My final question is, what sort of tips or advice can you give to people, potential applicants for future grants, applying for future grants?
Well, I was very grateful that we were able to apply to the Scoliosis Research Society for this grant, because it is a very specific project only relating to one small group of patients with adult spinal deformity. By SRS terms, that's not a small group of patients. But if you go to a public funder such as the National Institutes of Health Research, NIHR, in the UK, that is a very small group. And they would not necessarily have been interested in funding this project, at least not at this stage, because there's no obvious immediate benefit to the healthcare system. Societies like SRS, I think, fulfill a very, very important role by funding projects like this. In terms of what's important is that, of course, that now the process has a bit changed in how to apply for grants. It used to be a one-step process. Now it is a two-step process, which involves a so-called letter of intent, so a stage 1 application. What is really important is that the project is really relevant to scoliosis research and especially deformity research, that it is in line with the mission and the purpose of the society. And this is what the research grant committee will look for.
I imagine that the way patient-reported outcome measures work in the NHS is perhaps different than in the US, because the NHS has this long history of quantitatively assessing disability in terms of deciding what treatments it's going to pay for. And in some senses, I think in the US, we've been a little bit behind the curve in terms of quantitatively assessing the disability amongst our patients. In that context, I want to ask you how you currently use patient-reported outcome measures in your clinic. Like, what percentage of patients who come through your clinic and your practice actually fill out patient-reported outcome measures now?
Well, we have the British Spine Registry now. So in theory, all patients that have surgery, at least, should be put into the British Spine Registry. And we have a person dedicated, a dedicated admin person for that, because as surgeons, we're just notoriously bad at doing this, right? That's essentially the British Spine Registry. With regard to the healthcare system, well, I mean, the NHS has mostly used, we have the NICE, the National Institute for Clinical Excellence, and they use evidence that's been produced for meta-analysis that then informs health policy, also with regard to funding procedures. For example, back pain, surgery for just back pain is currently not funded in the NHS, not just due to the lack of evidence, but because of the evidence that we have from like 15 or almost 20 years ago has shown that the complication rate with surgery is just too high compared to non-operative treatment, such that for the time being they have recommended not to fund it. That, of course, may change as different evidence comes up, and there is now also an interest to actually get more evidence because surgical techniques have changed over time.
And how about, so when you have a patient in your clinic who fills out an outcome measure like this, do you sit down and discuss it with them, and do you have access to their results in the moment, or is this something you're looking at later?
No, it is just it's just an overall kind of idea or gauge where that patient is, on the spectrum that you see. But the current scores, they don't allow to make individual personalized decisions. Those scores have not been validated or designed for this. Some people would like to use them for that, but that's actually not how they have been designed and validated.
And one of the challenges that we have as we try to ramp up the percentage of patients that are filling out these measures is that patients do not want to spend extra time filling out these surveys. It's a big challenge for people to sit down and answer surveys where a bunch of the questions don't seem relevant to them.
Yeah.
And one of you mentioned the promise in your talk, and one of the ways that the promise has tried to address this is through computer adaptive testing, where if you answer one question that defines your abilities in a certain level, you won't answer a bunch of later questions that might be irrelevant to you. Is that something that you've thought about for this score?
Yeah, well, promise computer adaptive testing, of course, is the items that are used in computer adaptive testing need to fulfill the exact same requirements that we want to fulfill with this core. They have to be in a linear scale and have to be unidimensional. Well, they don't necessarily have to be unidimensional, but it has to come out then as a unidimensional construct. But that's the problem, it is different in every patient, and I'm not so sure how disease specific that really is. Then, if although it is a linear measure that we get, but essentially we're still applying kind of a different scale to every patient. And people working on promise and computer adaptive testing probably may disagree here. But, intuitively, that doesn't necessarily make sense. So I'd like to have a consistent ruler, a consistent tool that has been shown to behave in a certain way in the populations or in the patients that we'd like to measure. That I feel more confident with.
Great.
Well, thank you very much, Dominique and Dr. Vorhies, for this. Thank you very much.
Thank you for having me.
No problem.
Pleasure.
Thank you very much.
All right. So it's my pleasure to now introduce Dr. Rene Castelein. Dr. Castelein is a professor of orthopedic surgery and chairman of the Department of Orthopedic Surgery at University Medical Center in Utrecht in the Netherlands. He did his residency in the Netherlands and then his fellowship in the U.S., as I understand it, at DuPont under Dr. Dean McEwen at the time. So thank you very much for joining us, Dr. Castelein.
Thank you, John. It's a pleasure to be here. Thanks for the invitation.
Of course. So we heard a little bit about the structure of the SRS governance from Dr. de Kleuver as the Research Council Chair, and he told us a bit about the Research Promotion and Oversight Committee. But as Chair of that committee, can you tell me a little bit about what your responsibilities are and what the roles of that committee are?
Well, of course. This is a new committee that was chaired by Douglas Burton last year, and I took over at the last annual meeting, the virtual meeting in September. This committee was really organized or formed to make sure that we have at least as much as possible a view on what's going on with the SRS grant money, the money that has been awarded, where it goes to and what it leads to. So this committee oversees the different projects that have received a grant, whichever type. We also want to, as part of our mission, to emphasize the role of the SRS in promoting research into spinal deformities in a very broad sense, so adults as well as pediatrics. So I think that was reflected by the program that we organized just recently, having both adult and pediatric topics in the program. So I guess that's the most important task of this newly formed committee.
That's great. Dr. de Kleuver mentioned that there hadn't really been a formal process for following up on what happens to this grant money after it's awarded, and it sounds like the Promotion and Oversight Committee is a structured way of doing that. Are there any specific standards that a grant recipient needs to follow and can expect for how the results of the research are supposed to be disseminated?
Well, there is this one sentence that's always mentioned, that the SRS should be mentioned as a sponsor of the research, and that the eventual presentation should be submitted to the SRS annual meeting or the IMEST. But that's basically what it is. And then, as it goes, these research projects usually take many years before they're finished, and sometimes you sort of lose track of what has happened over the years. And this committee is really meant to sort of get more of an overview of what is going on, and whether a specific project has led to a presentation at the SRS or a publication. And what is very important is that both at the presentation, but also for the publication, the SRS is mentioned as a grant giver. I think there was pretty much of an idea of what was going on, and Virginie Lafarge had been very active in past in organizing what has been done and what was going on. But I think there's always some room for improvement, and this is what this committee is about, and what we're supposed to make a little bit better than it has been in the past. Although like I say, there was always, of course, an effort to make sure that the money was well spent, and that there was at least information on what has been going on and what the different stages of the projects were.
That's great. Well, I think the Outcome Symposium is a great step forward, because it allows a slightly bigger format to present some of the results of these grants, because they are often, like you said, complex multi-year projects.
Yep, that's true.
Great. Well, I wanted to ask you a little bit about your career and how it's developed in the SRS for some of our members who are earlier in their career. I wonder if you could tell us a little bit about how you came up in the SRS and started to become involved in governance.
Yeah. Well, I think when I look back on how that went, it knows pretty many different periods in my life. I was a general orthopedic surgeon for quite a number of years. I started actually in a very peripheral practice without any training program and without any research at all at that point. And that gradually evolved over a couple of years into a bigger training center in the Netherlands, and I became the head of that training program. But that was not a university practice, so the emphasis was very much on patient care, and I had a wonderful time doing that. I think patient care and taking care of your patients as good as you can is really the essence of our profession, and that's what I really like very much also. I think that's a major responsibility. But I was always very interested in certain topics and certain research questions. And then at a certain point, I got asked to become the chairman of the department at the University of Utrecht. And I cannot say that I had very much experience in research. I mean, I've written a couple of papers, but not very extensively. And, I had a very nice life, very nice position at that peripheral practice where we had just started to build that training program. And I was really very much in doubt whether I should do it. And the real argument for me to do that, to move to that university practice and become the chairman of the department, was that I thought I could explore my research interest more there than I could in the more general hospital where I was. So I went there and met, all the different aspects of academic life, with some struggle and some bureaucracy and some difficult processes that could not easily be changed. But then, after only not too much time, I would say, that's really started to become my home and the place where I really enjoyed, again, the patient care. Patient care was a little bit different. My patient care had always been very much in spine, but also more adult spine at that point, adult degenerative, than pediatric deformity, although I did pediatric deformity as well, but I also did hips and knees and other more general stuff. Gradually, my practice evolved towards more and more the thing that has always been very close to my heart, and that's also why I did that fellowship with Dean McEwen, who's really been a mentor and an example for me throughout my professional life. So one of the reasons I went there was to get more involved in scoliosis and know more and learn more about scoliosis. So my practice started to be organized around scoliosis and different types of scoliosis, idiopathic, but to a large extent also neuromuscular and congenital and syndromic scoliosis, because in the Netherlands, actually only the academic hospitals take care of the more complex patients. I mean, a idiopathic scoliosis can be a very complex scoliosis, but the patient is basically pretty healthy and doesn't have too many comorbidities, I would say. But the academic hospitals are specifically meant for the more complex patients as well. So a large part of my practice was in neuromuscular scoliosis as well. In the meantime, my research in scoliosis was evolving and developing, and I've always had a very strong interest in why this very mysterious disorder occurs to previously healthy children, and all of a sudden they start growing in another way than they had been before. And as far as I know, the scoliosis patients are pretty much healthy until the moment the scoliosis hits them. It's always been a fascinating topic for me, and I started to do more and more research in the field of the early phases, the early stages of scoliosis, idiopathic scoliosis, and what the early three-dimensional characteristics were. I was very interested in the early phases, so I was happy enough and fortunate enough to be able to do some research on normal spines in 3D as well, the rotation of the normal spine and, well, like I say, the early phases of idiopathic scoliosis development. And that brought me, of course, where else? That brought me to the SRS, and I started attending meetings and presenting at meetings, and then gradually, by getting to know more and more people and being more and more involved and being present at the meetings, at the IMS and the annual meeting, and being at courses and presenting at courses and being an instructor at courses. That's how it goes, I guess. And then I got invited, for instance, this committee, the Research Promotion Oversight Committee. I would say one of the highlights in that whole trajectory was that I got invited to do the Harrington lecture at the 2019 meeting in Montreal, which I thought was a very big honor, which made me be aware of the fact that it's been a very fortunate and very interesting journey in the field of scoliosis and the field of the trying to sort of clarify a little bit, at least, of the pathomechanism of how that disorder originates and how it develops. And I'm not saying in any sense that we're there yet. I think we're getting more and more information, but it also leads to more and more questions, of course. So we're still pretty much underway. And I've had a number of students that have worked with me, and they were great people that did a lot of work in this field. And I was very fortunate to work with them and still working with them. So I guess that would be a brief summary of what I would like to say about what you just asked me, but I could talk about it for another hour or so. Thanks for the question.
Well, it's interesting stuff. And I think it's really interesting that you described that you really started your career being 100% clinical.
Yeah, absolutely.
And you've ended up in a having your research interests be very basic and fundamental. It's a lot of the people, I think, who are doing great work into trying to hammer out the etiology of idiopathic scoliosis have more basic science training and backgrounds up front. I wonder, there's a lot of emphasis now in people who are coming out and coming up in training now to specialize early. And a lot of people feel that they need to get multiple fellowships, graduate degrees in research and pick sort of a niche very early on. That seems to be sort of the opposite of what you did. And I wonder how you might comment on how someone can reconcile those things.
Yeah, well, I agree with you, and I realize that too. And also in our own training program, we've gone to much earlier specialization and fellowships, and people taking up shoulder or knee at a very early stage and digging into that in a very, very deep and much deeper than I ever have, probably. I mean, I was trained as a general orthopedic surgeon, and which meant that I basically in my training I learned how to do a hip prosthesis and a meniscectomy and maybe a hallux valgus correction, and that was I guess I must have learned a little bit more than that, but that was a pretty basic general orthopedic training. And when I was in my first years in general practice, I was very broad, or at least not very specialized at all. I mean, I don't intend to say that I would be able to take care of a difficult scoliosis at that time, but I did spine surgery, but I did hip surgery and revisions of hip prosthesis and trauma. Did a lot of trauma at that time also, but not at the level that I think people reach right now. I mean, if you're a trauma specialized orthopedic surgeons, I'm sure you can do a pelvic fracture where I could not probably get anywhere near. And the same goes for all the other subspecialties. But there's something nice about being trained in a little bit broader way, which means that you can sort of take some different venues during your career also. I mean, until I started my academic practice, like I said, I was more into degenerative spine and doing some cages and fusions and decompressions and those kind of things. Also still doing hip surgery and things like that, which is nice because the hip is not very far from the spine. So if you know the hip a little bit, it's nice if you later on start doing more and more spine and doing less and less of these other types of surgery. I think it was nice. For me, it was nice to have a broad training. But I think nowadays it's probably a lot better that people specialize with a lot more knowledge. The field has become a lot broader. I think there's many more techniques nowadays than only a couple of years ago. It's going very rapidly. So I don't think there's really place anymore for a very general orthopedic surgeon like we maybe knew a couple of years ago.
Sure. One of the things I found really interesting being involved in this international society is how labor is divided among doctors and surgeons in different countries. Yep. You know, the divisions between what a knee surgeon does in, Australia is very different than what a knee surgeon might do in the US. You might focus only on degenerative practice or only on, a young athletic population.
Yeah, yeah.
But, as we understand more the dynamic interactions of the hip and spine, functional interactions of different parts of the body, our a priori divisions of what a surgeon does might not make as much sense.
No, and that's true. And that same holds true, of course, for spine surgery, where the distinction between orthopedic surgeons and neurosurgeons may be very vague and people go into each other's area. And I'm very happy that we have a very good collaboration with neurosurgeons at our department. I don't think it leads to very much if you really try to draw very strict boundaries between specialties. I mean, if there's interest in one field, then people, as long as they're competent, they should be able to do it, not based on what their background is.
Mm-hmm. I'm sure that kind of collaboration has helped you in your research delve into more aspects of basic science and imaging and such. So I wonder if you could tell us a little bit more about your research and how SRS grants might have helped that develop.
Yeah, certainly. Well, to start out with how the research developed, when I came to the University of Utrecht, I was not even really aware of the fact, but I could have known, and I knew it a little bit, but there's a very strong imaging department there. And I got in touch with these people because we met at certain meetings and we started discussing, and we shared a sort of a similar interest. I was interested, for instance, in how the normal spine is rotated. I was at least I had the feeling that the normal spine could not be totally straight. I thought if you would look at that normal spine of someone without scoliosis, I was sort of expecting to see sort of a rotatory pattern in that spine, because I could hardly believe that the whole thing is totally symmetric. Nothing is totally symmetric in the body, I guess. So I was discussing that with the head of the imaging department, who was an imaging engineer, not a doctor, but he worked at the university hospital as an imaging engineer. And he said, wow, that's interesting. Let's sit down and discuss how we could figure that out. And I had some ideas of how we could do that, but I needed a database of CT scans. I thought I could do that on a CT scan, not knowing exactly, as far as technicalities is concerned, how that should be done. But then he said, we have a big database of all sorts of people, normal people that were scanned for pulmonary problems, for cardiac problems. Let's take a look at that. And we started looking at that, and I saw that this sort of a predictable rotation was present, and he figured out a segmentation way how you could pretty easily measure that. So that academic environment really helped a lot. I could never have done that in my previous hospital, where these very smart and more basic scientists were not available and not around. So that's how it started, and how I really received a lot of help from people that thought it was interesting, the kind of questions that I tried to figure out. Plus the fact, of course, that my department at the University of Utrecht had always been very much focused on spine anyway. Also, my predecessor, Ab Verbout, the former professor of orthopedics and the head of the department, he was a spine person too. He was very much into the embryology of spine and congenital scoliosis, those kind of things. So there was a big history of spine anyway. And Schumer FC owner, whom the fracture people, I'm sure, know pretty well. He's a good friend, and he's at the same department. And Moyo Kroot, who is active in SRS and publishes a lot with me, but also on his own on scoliosis. He's at the same department. And Tom Slusser is another name. He's a former PhD student of mine, did his thesis on scoliosis, and he's at the same department. So there's a strong history of spine and also a lot of interest in spine from many people. So in discussing and in interacting, that always leads to many more interesting questions. So that's how it more or less evolved. And then when I became member of the SRS in the beginning, I was a little bit, of course, as it always starts, a little bit of an outsider. But then after a pretty short period of time, because it's not such a huge organization, it's a little bit of a family too, I would say. And after a while, you get to know a lot of people, and then you become aware of the possibilities. You start presenting at a meeting, and then you realize that the SRS is also able to grant your research if you have a nice project. So we submitted, for instance, a very, very recent project on a certain genetic syndrome, which is called the 22q11 deletion syndrome, which we figured that maybe could work as sort of a model for what we're trying to figure out in idiopathic scoliosis. So this was granted, and research depends on ideas, but it always also depends on money, because you have to have your bench fees, and you have to have people, and you have to have all sorts of things that won't work without money. So the money is very important in getting research done, and I'm very grateful also to the SRS to have supported parts of that research. The other thing is I got in touch with the Cottrell Foundation, and that's another grant that the SRS offers together with the Cottrell Foundation. But I've been a member of the Cottrell Foundation for maybe 15 years now, and they actually started to fund my very early research, and I'm very happy because they have annual meetings. Well, they haven't been going on for the past year or a little bit more now due to Corona. But basically every year in the fall we meet in Paris and we exchange ideas and presentations, and that's a very nice and very scientific group, I would say, with many, like you said before, many basic scientists, geneticists, biologists, molecular biologists, people that really dig into it much deeper than I can. But I'm a clinician in that group, and there are more clinicians, so that interaction is very nice, and I'm very happy that they joined forces with the SRS, and that right now we have the SRS Cottrell grant also. So that's how it started, and that's how I got supported by organizations that have been very important for me to be able to do what I like to do and what I've been doing.
Great. Thank you. Well, I think that's we're coming up on the end of our time that we had together. Is there any other things that you wanted to mention or messages for our audience?
Well, it's wonderful to have this talk with you, and I think the SRS is a wonderful organization. I really have good friends in the organization by now, and I've been missing people, missing seeing them live, and I'm happy that we've discovered a little bit of this online format that works to a certain extent, but I certainly hope that we'll be able to meet in person again before the end of the year, hopefully at the annual meeting or whenever it's possible. But I certainly hope to see my good friends at the SRS sometime soon. That's what I hope for.
Me too.
And I would encourage young people with any ambition, clinically or scientifically in the field, to become a member of the SRS, because it's a great group of people.
Great. Well, thank you very much. It's been a pleasure to have you today.
Thank you very much.
Thanks, everyone, for joining us for another episode of Scoliosis Dialogues.
Thank you also very much for joining us, and see you in the next dialogue or podcast. Thank you.
The Scoliosis Research Society is a nonprofit professional organization made up of physicians and allied health personnel. Their primary focus is on providing continuing medical education for healthcare professionals and on funding and supporting research in spinal deformities. Please visit srs.org for further information.